Right. So I am personally thrilled to see so many people here, and it's just a testament to Rochelle Dicker and the wonderful work that she's doing. Rochelle asked me who's in this room, and it's so great to think about who's in this room because we have people from the Center for Vulnerable Populations. That's the home where we are here, and it's one of the things that we've been wanting to do is to have really this be a forum, this seminar series where people from different divisions, departments across campus can really come and talk about our common interests. We have people from our Center for Health and Risk in Minority Youth and Adults, which focuses on chronic disease in minority youth and adults. We have people who have seen the flyers and have wandered in. Fern is here on her day off, which I love. Howard is here, and Howard doesn't even work on this campus, which is awesome. Naita's here. She's a new faculty member here at SFGA. So we have lots of wonderful people here, and we're thrilled. Rochelle is really wonderful. So Rochelle is, I've known Rochelle since I was like a trainee, and she was my fellow or faculty member in the ICU. Scary. Wow. But now I love running into Rochelle because she is going to tell you about the wonderful work that she does, and she says, but really it's also about the diabetes and the fact that people have, who are getting shot also have these other things going on. So she's a wonderful colleague and collaborator, hopefully in the future, and I want you to hear about her work, and so we're thrilled that she joined us.
Wow, thank you very much. And I couldn't be happier to speak to this group because really we are all one and the same, right? The idea that our shop is just a couple blocks away is just anatomy, but really our physiology is the same, right? So no silos, and I really do look forward to more cross-pollination here. So, so just as a little bit of an introduction to the wraparound project before I go into some of the details. When I was an intern at San Francisco General Hospital, I took care of a 16-year-old who was shot, and he was from the Bayview. And he was recovering from his wounds, and as an intern there's not a whole lot you can do, particularly from the surgical side, except you can bond really well. And this young guy ended up playing a major role in how I was going to move forward, because I wasn't sure how to reconcile this idea of wanting to do public health with really loving the idea of using my hands and being a surgeon. So he left, but before I went on to my next rotation, he came back and got shot again. This time he went to the ICU. And he made it through that second time, but I'll never forget the first time when I asked him, what are you going to do from here? He said, I'm really not sure. I mean, what can I do? And it was a profound change that occurred for me, because I felt like I'm going to be a surgeon and now I'm going to learn how to stitch him up, but I'm going to send him back out in this same sort of a situation, and there was no sense of the kind of risk factors and protective factors, the paying attention to social determinants that we think of with things like heart disease and diabetes, and it didn't seem right. This was a public health issue. So that was the beginning of wraparound. So with that, I'm just going to give you a little bit of background. So we think of San Francisco a lot of times as, sorry, I'll get to know this, as this, right? And now we have a fabulous new Bay Bridge, but I just was underneath that fabulous new Bay Bridge yesterday. It was a little rusty. So that said, though, a little bit. It's a little sketchy. But this is also San Francisco. And this is the San Francisco that oftentimes we see through the eyes of our citizens who are coming in, shot and stabbed. And this is also San Francisco. This is the Mission District. This isn't the part of San Francisco that our tourists are privy to, but in fact it's still part of our community. So, and the part of San Francisco that is more liable, frankly, for being in these areas and being susceptible to the kind of violent injury are these guys here who went on this Yosemite trip as some of our graduates of our wraparound project. And so this is our vulnerable population that we deal with on a regular basis. Injury itself claims about 6 million lives worldwide every year, and we're involved on a more global surgery type of initiative. So from a surgeon's perspective, it's not just about vaccinations and malaria and tuberculosis, but in fact, injury is a major public health issue. And this was in Sri Lanka. This is their form of injury prevention around the time right after the tsunami, where really the bigger issue was some of these landmines that were coming to the surface, and we were dealing more with people who had explosions around the ankles than with the outcome of the tsunami. And then there's this in our country, firearms and the Second Amendment, and this has gained a lot of attention, of course, recently because of Newtown. And the Second Amendment reads, a well-regulated militia being necessary to the security of a free state, the right of the people to keep and bear arms shall not be infringed. That's our Second Amendment, and then the interpretations go from there, just to mention. So this is the burden of firearm-related violence in our country, and just to give you an idea of the ownership from 1959 to 2010, pretty steady. And there you see the percent with a pistol or a shotgun in the home has declined to some extent, but really the percentage of guns in homes has remained pretty steady. How are we different? I'll show you a couple different statistics about that. For other so-called civilized countries, the gun ownership is way down in here. So these are assault deaths in other countries, and here's the United States. So we've made some progress over the years, but if you compare us to other countries, have we really made that much progress? And this is what firearm-related violence looks like in our country. So the red areas are where homicides are really responsible for a significant amount of deaths, and it affects a younger population. So the reason that Kirsten and I have bonded is with this idea that it's not just about the individual, right? We have the younger set susceptible to the issues that I deal with from a clinical standpoint, and the middle and older set of other chronic diseases. So the community as a whole is completely affected by this because it stretches along the whole life spectrum. So trauma is a public health problem we know of vast proportions. It's the third leading cause of death. And it's the leading cause of death in ages of people 1 to 44 years old. That's any kind of trauma. About 150,000 per year and 400,000 persons disabled per year. It's probably an undercall. And it costs 3.6 million hospital admissions that are greater than 7 days. So it takes us a long time to get a gunshot victim out of the hospital, well enough to be out of the hospital. And it costs about $11.8 billion, which is about 6.9% of healthcare. And as I mentioned, it's a disease of the young. Injury is the leading cause of death and disability worldwide in people aged 60 and under. And we probably only know the tip of the iceberg globally because our surveillance isn't that great. But if any of you want to be involved on a more global level, we have projects in East Africa right now to do a better job of surveillance for injury. And this, again, is another way of showing how the United States is a standout from other countries in terms of our burden of homicide. 17 times more likely than Finland, which is the next one.
Why do you think that is?
For
the United States being such an outlier?
it's several things, and Dr. Howard Pinderhughes, who we're privileged to have with us in the front row here, can speak volumes about this. But a lot of it is about just access to guns itself. A lot of it is what's happening as far as what is a chronic disease of violence in our country. It's generations, I think, of the idea of violent injury. It is disparities, and we can have more of a conversation with that I know Howard can speak volumes about. So it's an incredibly complex sort of a question, and I think it is unfortunately a part of our culture right now that it's up to us to help break. So we were looking, there was a level 1 trauma center in Texas that looked at deaths in trauma centers. We go through our morbidity and mortality, right? And what we found was that we really couldn't prevent over 50% of the deaths. In other words, we did our best, but people's head injuries were too much, and their overall constellation of injuries was just too much for us to save them. But that didn't mean that we couldn't do it. It just meant we needed to prevent it from the outset. And that's why a lot of us are spending our lives in prevention. So the media portrayal oftentimes is that of the middle class, and it started with Columbine in many ways, but really the disease is different than a lot of the media portrayal. And it came to the surface in a positive way in terms of getting people energized about the gun violence issue in this country as far as what happened in Newtown. But again, it's really important to understand who really bears the brunt of this. So the severity and disparity of homicide in youth and young adults. It's the #1 cause of death in young African Americans. #2 in Hispanics. And in 2005, 15 youth were killed per day. So 53 per 100,000 African Americans are affected, and 20 per 100,000 Hispanics. That's Mike right here. I like that. Thanks for your sunglasses. There are over 100 non-fatal injuries for every homicide, and this is what we get to pounce on from the standpoint of the Wraparound Project. It's probably a gross underestimate because these are the ones that show up in our emergency departments. We don't account for all the ones that show up in primary care or don't show up but have those injuries. And it is a disease of the young. 560,000 potential life years are lost. And the cost of intentional injury is $178 billion per year. Injury recidivism rates are as high as 55%. Right now, Chicago is just a mess with injury recidivism. The group that we met with 2 weeks ago in Philadelphia, we were kind of comparing and contrasting, and it looks like right now Chicago is really very heavily burdened. One firearm victim exceeds $30,000. We here in San Francisco, it's more like $35,000, $40,000. And just to preempt, we just completed a study using a Markov analysis, which is a cost-effectiveness analysis, and found that I'm jumping way ahead, but I don't have any slides yet, that our violence prevention program is more cost-effective if you put it in perspective with other prevention programs than mammograms. So it makes sense to have these programs. So the politics of hope, because we want to talk positively now. Hope is a state of mind, not a state of the world. Either we have hope within us or we don't. It's a dimension of the soul and is not essentially dependent on some particular observation of the world or estimate of the situation. It's an orientation of the spirit, an orientation of the heart. And that comes from Václav Havel, who was probably a better poet in the Czech Republic than president, but he said it, and that's what we have to go to every day when we go downstairs and see another young victim. It's not about that particular situation, and all of us who work with Wraparound have to know that there aren't going to be 100% successes, but we need to keep striving because it really is a sense of spirit and what's possible. So who owns this problem? Is it a law enforcement issue? Well, we think there might be a role to that, but as far as prevention, one of the E's is enforcement, along with education, environment, and so forth. But we also feel like we own that problem. So way back in 1984, C. Everett Koop said violence is actually a public health issue. And then by 2000, there was this youth violence, a report from the Surgeon General about risk and protective factors, and that became kind of our beginning point for how we start a wraparound project. And there was a surgeon in Pennsylvania who was very encouraging. He's the one that coined the idea of the bullet as a pathogen, and that aren't we at a good vantage point as clinicians to start addressing this problem. And why would that be? Well, there is a golden window of opportunity that I'll discuss with you more. So Public health meets public hospital, here's where we are. So we want to define the problem in the public health model. And so for that, we look at our trauma center and we say, yeah, we have a significant issue, and this is just 2002 to 2005, and if you go the next 5 years, the next 10 years, it's the same sort of pattern. It's really hard to save somebody from a gunshot, period. It's just, the best trauma surgeon will say, it's really hard to save someone from a gunshot. It's much different than dealing with stab wounds by far. So what you see is that the number of patients versus the number of deaths, the proportion of people who die from gunshot wounds is extremely high. Our trauma center is very close to ground zero in a lot of ways, so we have the opportunity to save people because the transport times are only about 7 minutes. But still, we're managing a disease that is incredibly difficult to control once it's done. So we did surveillance, and we found that 76% of homicide and assault victims had criminal histories, and African American men are 13 times more likely to be injured. This was part of a project that was piloted through a Harvard project, and some cities still have this violent injury and death reporting system. We have it pretty well managed here between the Department of Public Health and the trauma registry data here because we're the only level 1 trauma center. And so we've kept track of this to make sure that we're really pinpointing the appropriate people to target for our prevention efforts. 2 per 1,000 African American men are injured from violence. And only about 6% of the city of San Francisco is African American, but they make up about 60% of the gunshot victims. Illicit drug use, when a case manager conducted the survey at the bedside, 65% said that they used drugs. When a traditional healthcare worker asked the question, only about 20% said yes. And we found that the unemployment rate was 73% amongst victims of violent injury who were of age to have a job. Many were over 18, not 16. And 56% had a high school graduation or the equivalency of those who were 18 or over. We had at that time in this hospital, we had a 35% recidivism rate. So that's a re-injury rate over a 5-year period. And 88% said that they did want services, they wanted help. So we identified the risk and protective factors. And so this is a pretty rudimentary, just a global idea of risk and protective factors. It's much more complicated than this, but generally, in a general sense, poverty, family dysfunction, guns, lifestyle choices, substance abuse, lack of role model, educational deficiencies, hopelessness, and recidivism. And then protective factors, we know adult mentorship, interpersonal skills, commitment to school, access to resources, and then a paper that was published in Science way back in the 90s read that social cohesion and a willingness to intervene for the common good reduce violence. It's easy to say, but it's not so easy to enact if you have a lack of these other things, such as viable economic options in communities. So what's the trauma surgeon's role, or what is the trauma center's role in all of this? Well, we think that there's a teachable moment, much like you think of in terms of heart disease. So it's the opportunity after someone's had an event to go to the bedside and say, okay, let's team up, and what is necessary? Well, let's try to get your cholesterol under control. We'll put you on cardiac rehab. We'll go through diet management, diabetes control. These things apply to our clients who are victims of violence as well. And then we need risk reduction strategies by that public health model. And we need culturally competent case management or culturally sensitive case management. Going to the bedside as a traditional healthcare worker is not necessarily going to have the same effect as someone who gets it. Someone who has lived in that environment, who gets and understands urban violence and can immediately develop a rapport. And then we can't do this in a vacuum. The community and city partnerships that we've developed over the years and essentially having case managers who come in from the community and already they are the connections has been absolutely essential for the program and for many programs in the country. So then you want to develop and test prevention strategies. So again, the cornerstones, the public health model, seizing that teachable moment, long-term culturally competent case management, and then providing links to risk reduction resources. And just as important as hanging in there with long-term case management is to be realistic with people. I mean, we can't say we will get you a job. We're trying to tighten that up and have our own opportunities and our own ties to vocational training and employment, but we can't guarantee things. So being realistic is really part of it, but also having this partnership. And the case managers can't do it on their own. They really depend on this idea of partnership. A lot of times our clients are used to being let down by community-based organizations. They lose their funding, they don't quite deliver what they set out to do. So long-term appropriate mentorship in case management has been a real boom, and people have come back. Mike and Javier have been with me for years, and it's critical that after 3 years someone may come back and the door is open to them, and that's provided a real sense of security. So we aim to provide tertiary prevention to reduce recidivism and incarceration, and to reestablish ultimately the standard of care for violent injury in our trauma centers. So the teachable moment, working knowledge of urban violence and the experience of overcoming violence, crisis management, and being a positive force in the community. And you're looking at 2 out of 3 of the case managers who are so incredibly well respected in their communities. And I just feel blessed every day to have that component of it, or else we wouldn't be anywhere. And that's actually a former case manager who's not on bigger better than. So I'm just going to move to the next. I want to show you this. So when you're setting up a program like this, just like any kind of a prevention program, there has to be a feasibility component to it. And that doesn't just mean that you have the capacity to sustain it from a funding standpoint. It also means that you actually are going to stakeholders and that they believe you're not going to disappear, and that they have buy-in, that it's their program. In many, many ways, Wraparound Project is a community-based organization. Picking the first case manager, the community panel picked the first one, and from there we have subsequently gotten case managers from community, not from my chair of the Department of Surgery and so forth. It also is important that we exist within the structure of social services at San Francisco General Hospital, or wherever, whichever hospital a program like this is maintained. So we work hand in hand with social services, and we need them. We work a lot of times with the Trauma Recovery Center. Mental health services are critical. So these are components of it that we're all just brothers and sisters in this, and we don't supersede any of these other components. And then as far as just the climate in the hospital, we are incredibly fortunate to have the backing of our foundation at San Francisco General Hospital, and Kelly Lang is here to represent the foundation. Without that, without the backing of our CEO of our hospital, these have been absolutely critical for our success. So wraparound algorithm isn't very complicated. The case managers go to the bedside and see people as they're recovering from their violent injuries. If they're in the intensive care unit, they start making that connection with family, next of kin. And when that particular client is ready to have someone come into the room, and that's mentally and physically, then the connection starts. If they're deemed that they're high risk or maybe even medium risk, they enter into a whole needs assessment. That might be tattoo removal, it might be vocational training. If they're younger, it may be moving to another school to be safe, or talking to counselors at that particular school. Oftentimes it's mental health services, and we've found some of the most critical components of this. And of course we don't work without the family, as the family is still involved. then they're drawn into the circle as well, to be able to not just address one particular component, but really multiple factors. The case managers spend a significant amount of time in court, and oftentimes part of the release of the particular client is that they follow up with wraparound. So we've worked with the court system and with POs to be able to afford that opportunity. So the community response networks, Live Memorial Church, Brothers Against Guns, Caressin, tattoo removal, these are just some of the programs that we have worked with. And some programs may be in the East Bay to be able to provide long-standing services to our clients. Community-based organizations come and go because of funding streams, but we make those solid connections. Oftentimes they're individual and personal connections because our case managers know people working in these places, and it's given our clients a lot of opportunities. So this is just a really quick way of showing, because I always know in a group like this, well, how do you record all this? We have a database from a group that's down in Menlo Park. It's called Question. I don't have any proprietary reason to boast them, but they have done a great job with being able to, and the case managers have invested in designing it to be able to input information so that we can keep an accurate track of how we're doing. So this is kind of what it looks like, individual screening page. So we screen our victims, and if some people are not really eligible for wraparound because they're really not high risk, then we help them with the victim of crimes application and so forth. If they're older, we refer them to other community-based organizations because our catchment is 10 to 30, although we're rethinking that because our population who is getting injured in San Francisco is getting older. And so we keep track of all the different reasons that we have or have not enrolled people. And then this is how we keep track of our needs assessment. When did we identify the need at the bedside or later? And how did we do? How long has it taken us to get somebody to the point where they can get a driver's license? Why is that important? It opens up a whole host of other job opportunities. I mean, and in fact, there was one individual from our Friends of the Urban Forest MetaFund program. Friends of the Urban Forest, it's an arborist vocational training program with a great opportunity for a job after that. And Friends of the Urban Forest asked, well, we want to teach him how to drive a truck, and so we have to step back because he didn't have a driver, because the individual doesn't have a driver's license. So we need to go through that route. Okay, well, how did he lose his license, and how can we get that back so that he can move up and beyond in this group? So we do 6-month follow-up, but in all honesty, how many times do we sit in meetings and talk about, oh, you remember so-and-so, they came back, and so we don't lose track of a lot of people. And then some of the longer-term follow-up, maintaining commitments, we do try to have final sign-outs because we know that we need to cut at some point, but they're always welcome to come back. So we do try to sign people out. Did you have a question?
Yeah, Rochelle, this is really great to hear about. I'm interested in if you ever refer people to primary care. I
We
didn't
do.
see that on your
Yes.
list.
And typically what I'll do is I'll have the guys send them to my clinic, and then I figure out and do an e-referral. I'll see them one time and then try to get them to a primary care. Yeah, that's a great question. And then we have a little bit of funding to be able to do internships and some work with the case managers. Sometimes it's a matter of being able to pay them hourly for a particular, look up how to do a CV template, something like that. And in all honesty, it may be because this is neutral. It's neutral here, and if we can hold them in our offices for a little while, it's a good thing. So if they can do a little bit of work with the case managers to keep them in a safe environment for some hours, we do that.
Rochelle, how do you, who's high risk and who's low risk, and can you meet the needs of all the high risk that we see?
you guys?
No, definitely not. There's our target population is the highest at risk of re-injury, and we really got to get that sense when we're at bedside how high at risk are they? And we may not determine that at that point. There's hopefully could be some rapport and some relationship building that lets us really get into peel some of the layers off to really figure out how high at risk this individual is. We get a good sense simply because just the vibe we get, and then some of the things we hear from the community, because we're so connected with the people that are out there. Hey, this gunshot happened on 3rd and Blue. We know that guy. He's definitely been out there. He's definitely on the block. And so we have those connections with our community-based partners out there that gives us more insight. We also get a police report from the DPH or some of the incident report of what might have happened that day. So we'll get that. We'll know, okay, from a police perspective, they're saying this is what happened. So we go in there kind of already knowing, okay, was this wrong place at the wrong time? And if so, how do we connect mental health services? Or if you're a low-level case, you're not that at risk, you're cutting school, you smoke a little bit of pot, you're necessarily not fitting our criteria because we are looking at the highest at risk of re-injury. And we just can't absorb everyone that's coming into the hospital. We definitely have to rely on referring out to be able to community-based organizations that are dealing with some of those low-level cases that are just, not necessarily the wraparound criteria. Granted, any of those cases that are low-level can immediately jump up to a higher level at one point or another, for whatever circumstances. So, but are we meeting the needs? I think that, a lot of these young men that are coming out, young women, once they've been caught up, they're really heavily involved. They seem to think that now that okay, I hear you, I get it, I almost died. I really do want to live. I need to. All right, I'm willing to hear you out. Let's go to your office. Let's sign whatever we got to sign up. So I should be working next week or 2 weeks from now, right? And there's this instant gratification that they're actually thinking is going to happen, or it's going to go on. Just because now they're like in this better place in their life, like they're really wanting something. They're like, okay, now that I want something like a job, because I've never really went to go out and try to find one, you guys can do that, right? You guys can make that happen. And, no resume, probably a felony or two, and it's really hard to make them employable. So, with that being said, a lot of that goes on, what goes on in wraparound is these young men are thinking about retaliation. They are thinking about what are they going to do with the next steps of their life, right? Am I going to get a job or go through a training or just come hear you out, because I really want to talk to you about this. I am thinking of picking up my gun, so we really try to discuss their first 24, 48 hours once they leave the hospital. That's very critical, it's so crucial to what's going to happen for the rest of their life. And then really try to bring them in and have that dialogue. It may not be that they're thinking about education or employment, but it's really kind of bringing them down and really making them realize that there is something to fight for in a positive way, and whether it's work or education or employment training. Hear me out. I can put you through these programs. Here, let me drive you to them, and so let me hook you up with people that I know at Goodwill or these other employment programs that I personally know. I'm not just going to call somebody and say, well, go meet them, and here's $2 for the bus, it's just, they may not get there, and so I got to make sure that those connections happen. And even when I made those connections, they just can't see 4 or 6 months away. Oh, it's going to take me 4 to 6 months to finish this training program? I can't do that. I can't do that. And then I get a call a year from now. Just the other day, this kid took him to Goodwill Industries. I pulled some girl out to have, she does, classroom settings to bring in people, right? So when she meets with people, she's like 40 people, and she's saying, you guys want this is what you got to do, A, B, C, and D, and C. And I said, I just need a one-on-one, you and my kid, please, he's ready. So I just need him to feel your energy as well. So we did that, and he's sitting right here, she's sitting right here, I'm sitting right here, and I suddenly look up at him and he has a joint in his ear, and then I wanted it. I was just like, but he didn't go through the program. He wasn't ready. And just a year of time went by, and then he calls me about 2 weeks ago, and he's like, I'm downstairs. And so he came upstairs. He said, look, I went to this training program for custodians, and I got the certificate. Please hook it up with a job. And sure enough, that he was working the next day. Not to toot my horn, we just employed somebody who is this employment specialist, who's education employment specialist in our team, and he's been making connections with unions and just really trying to get trying to create these opportunities that we're trying to get them to attain. And he was working the next day. He's just said, oh my God, you know. So that's a blessing. And you know, he was one of those really hardcore guys that just wouldn't get it. But I think the relationship he had with wraparound really made him think, like, you know what, I'm not gonna go retaliate. You know, I'm just gonna be cool. I'm just gonna try to live my life. Let me hook up with them every now and then. And we go out to eat a lot, you know, and we just have these deep conversations, like, you know, your life really looks so. So, you know, those are, you know, and then there are those stories that they do get the connections. They do get the mental health service, you know, they support. They do get, you know, through a training program. They go back to school, you know. And one of the beautiful stories that I have with a kid I took to City College is, you know, I go out there with him and we're just touring the campus and I'm just saying, yeah, man, this is all accessible. This is all, you could be in this, you know, 2 weeks from now when the semester starts. And there was a lot of people, you know, the people were registering and stuff, and then he sees a guy, he just said, I know that guy, you know, and you know, he kind of hid from him, but I'm like, so what's up? He's like, that guy's on the block all the time. I go, what times? He's like, like 6 p.m., you know, after that. I'm like, so all throughout the day, he's putting in some work that nobody knows about. Sure enough, he'll be gone before you know it, living a way better life. And you're just caught up in your hood, in your street, you know? Look what this guy's doing. And yeah, you know what, maybe he can't get away from it, but he's doing something. Get to work. And you know, he was just like, I would have never thought this guy would be in college. So he's like, I can do this, you know? I just gave him that kind of glimmer of hope that, you know, this is not as scary as I thought it would be, you know? So it's just something to work.
So I'm gonna just mention a couple of little things about some of our outcomes and let these guys field more questions. So as I mentioned, it's an assessment at the bedside, and it's so hard to capture objectively the high risk. You know, the nature of it has just been one of those things that they have their own internal criteria. And so our first analysis of it was an interim analysis. This was years ago already, and we had to really look ourselves in the face and say, okay, we're not perfect here, and so we looked at our different needs and the percentage of time that our needs were met from 3 to 6 months. So court advocacy, we were doing pretty well. Driver's license, not so much, because what we found was we were jumping the gun and people weren't able to really pass the driver's license because they didn't have the ability to read the test. So step back. Education, how often were we successful at really placing the younger kids in educational opportunities? Employment, over 50%, housing about 50%. We have a stronger connection to the housing authority that Mike was telling us about last week. But that's always a difficulty. Mental health and drug treatment, 65% of the time, and vocational training, 67% of the time. So this is being able to go all the way through these particular programs, and it's not perfect. It made us feel like, okay, we probably need to hold on to people longer. We need another case manager because we're overwhelmed, and we were able to get that from the city, and tighten up some of these things. And what are the essential risk reduction resources? So that's what we'll look at next. So we also wanted to look at the fiscal price tag, not just the difference that we were making in lives, but if we were going to go to particularly policymakers, funders who were more on the dollar side of things, then we had to come up with, you know, what is the difference in the funding. And we thought that the annual cost of injury is much higher than the cost of violence prevention with the wraparound project. And so at that time in 2007, our total expenses were under $200,000. We're more expensive now. And what we found was that the range of gunshot victims in particular, but stab wound as well, $6,000 to $389,000, and 83% were from public funding sources. So the mean was about $49,000. Gunshot victims are particularly very, very expensive to take care of. And what we found in this was that the wraparound project would be cost neutral if it saved 3 subsequent injuries. And it saves more than $500,000 each year. We have a more robust cost analysis that I just mentioned, and literally we finished that on October 1st for an abstract, so I haven't put it in here yet. But it's exciting to be able to compare it to other really tried and true prevention efforts, and have found that it is quite cost effective. So then disability adjusted life years after violent injury, and we quantified the economic and social burdens of violent injury. What we found, and I just threw this one slide in here, was that there was a 16% increase in disability adjusted life years if our clients had post-traumatic stress disorder. And we're going to be enacting a very short form to look at post-traumatic stress disorder. Some of our colleagues in Philadelphia have been doing this for a couple of years. Healing Hurt People is a program at Drexel, extremely sophisticated program. And they've been looking at PTSD for quite some time. We're going to start to put it in our analysis at the bedside so that we can get appropriate mental health care for people early on. And this is not simple PTSD, this is complex PTSD because it's something that didn't just happen at this one time that they were shot or stabbed. They've been living with it. So then we looked at our hospital-based violence intervention program and thought that it reduces injury recidivism. We wanted to know if meeting education and housing needs were independent predictors of success. And that's what we assumed were the most important things when we were looking at this. And then what dose? This was something, the idea of a dose was something that a colleague asked in another city. Well, how much, if you're designing a violence prevention program, how much time do your case managers need to work with people so that you can feasibly look at how much it's going to cost? And so what we found was that to break this down, we needed to do process evaluation, impact, and outcome. So this is what it looks like. For process, we wanted to determine screening, approach, enrollment rates. We kind of did that before. And so our inclusion criteria are years 10 to 30, and exclusion, we refer for domestic violence and child abuse to other resources in the hospital that have a different set of risk factors, although I would absolutely say that there's so much interplay with it, and I've come to recognize that more and more. So 848 over this particular period were screened, and 74% met inclusion criteria. And then out of the people who were eligible, we were able to approach 89%, and 11% were missed, typically because people can't come in and out. We're in the process of hiring another case manager right now who will be focused on Fridays and Saturdays most likely, because people come and go. It's really hard actually now to be admitted to a hospital, even to be really sick to get admitted. So we're missing a lot of those people who are coming in injured, and if I'm on call I get their phone number, but it's just not the same as having the case manager there. So that's why we miss people sometimes, just not 24/7 coverage right now. Then deemed high risk, 198 by the case managers, and low risk, typically the resources end up in social services and then referrals to the victims of crime office. We work really closely with them and give them a talk and stay in touch with them on a pretty regular basis. And then out of those, we had 30% decline. And the interesting thing about the declines, and you could absolutely say, well, these are the highest risk, but we're not 100% successful. Some of these, and we should be able to track them in our database, some of these patients and some of these potential clients do come back later, and the trigger may be somebody who has dropped off and then said, okay, I've had enough for whatever reason now I'm ready to be a partner in this. Or it could be that they continue to receive bills, and so they come to the case managers, it's like, you gotta help me with this. And I'll help you with the rest of it. So whatever the trigger is, we'll take it. So Latino, Hispanics, 26%, African American, 59%. And the reason that that is so high, as far as the capture rate that we have, is because a lot of the African Americans in the city are shot, and a lot of the Latinos are stabbed, and so they leave earlier. They're not as badly injured, so we don't get to them in time before they go. It doesn't make what's happening to them any less of a risk. So impact evaluation, we looked at our success rate. We're getting better, so this was our second time around. So we understood, as I mentioned, that getting a driver's license, you really needed to know how to read before you got there, and so we were a lot more patient with that. And we've done a lot better. Our teaming up with the Trauma Recovery Center has helped significantly too, in terms of mental health. And we wanted to determine the overall injury recidivism rate and compare it to our historical institutional control. So when I first started to do this, people said, well, you have to randomize. So you can't offer the service to everybody, right, to 50-50 or whatever. Well, that didn't, first of all, feel right. Something felt better than nothing, and plus I believed in what I was doing. But the most important thing was that the community said, why didn't someone come talk to my guy? And so there wasn't equipoise in the community. If there wasn't equipoise in the community, I was not going to randomize. It's just not okay for a parent to see a case manager going in one room and not going in another. So that wasn't, that wasn't going to happen. There is one randomized control trial in from the group in Baltimore that was written up about 10 years ago. It showed efficacy of the program. Arnell Cooper is the lead author. So our overall hospital injury recidivism rate we found was 4.5% from our control rate. Back in the 80s, our injury recidivism rate was 35%. We just looked at the injury recidivism rate for the last 15 years prior to the starting of this program. It was 16%, so we dropped our recidivism rate almost 4 times after. Now, obviously, there are a lot of other factors involved with that. The overall recidivism rate in the country was flat, so it was about the same. But there are a lot of confounders in that. But then again, we are nothing without our community-based organizations and distribution resources anyway. And then we looked to determine which risk reduction resources were independent predictors of program completion and success. And success we discussed as sort of an expert panel of the people who have violence prevention programs, and we decided no injury recidivism, and program enrollment greater than 6 months, meaning that there wasn't a high attrition rate, and that we met greater than 50% of the needs within a 6-month period. That's what this expert panel decided to call ourselves as a successful program. So given that criteria, our success rate, what we saw was that actually mental health and employment were independent predictors of success. So if you had a program, in other words, where you needed to focus on a couple of particular areas because you didn't have a whole lot of funding or your city didn't have a whole lot of resources, Oakland, then you want to focus on particular things. And what we found was that employment was absolutely key, and that mental health was absolutely critical. And now I'm completely on the bandwagon of these 2 things. These are our focuses, and we're grateful for any opportunities to work with people with regards to employment and mental health services. It's absolutely key. We thought that housing, and it's not to say that housing and education aren't important, but as far as independent predictors of success, those are the 2 most robust ones that we found.
Rochelle, what's the distribution of ages in your group? You're enrolling, I mean, you're hopefully not just employing the 10-year-olds. So how do you, are these mostly people who are of an age where employment is the thing you would go for?
Yeah, wraparound is a little unique. We probably have one of the higher average ages, San Francisco being not a lot of kids here.
I see.
Our average age of our wraparound clients is 22.
I see.
And you go to Oakland and that's not the case. The Youth Alive program in Oakland is actually, I think their average age is like 17 and a half or something. So yeah, the vast majority of our clients are within age of needing employment. And then we looked at what we call dose, and I love it when I hear the case manager say this. So what we found was that it's critical in the first 3 months in particular that they're spending an intensive amount of time. So higher doses, in other words, 3 to 6 hours or even 4 or more hours, were also independent predictors of success in the program. So there's just nothing like this mentorship. And it really is, like Javier said, it's not just here's $2 and go on the 9 bus to your job opportunity. This is really shepherding people through these resources. So over the 6 years that our institutional injury recidivism decreased fourfold, and providing mental health care and employment opportunities is predictive of success. The value of early high-dose intensive case management is successful. And what we don't want to see is this. So this was a 12-year-old who, or this was in the room of a 12-year-old who I took care of, who was shot in the neck. He was up on this pediatric floor, right, which was just a whole weird thing. So he was on the 6th floor, and I came in to see him a couple days after his injury where he could receive visitors. And he had up on his wall, "I know how you feel because I've been shot too, well, 3 times, and it hurt. So don't think I don't know how you feel." And this was from a friend of his who put this up, as on his cork board as a get well card with a semi-automatic drawn on the picture. So it is still an epidemic, but it's something that we can get our arms around and should take responsibility for reducing. With that, I just want to share with you the opportunities that have been given to us. The City of San Francisco and the mayor included, the Department of Children, Youth, and Families has been incredibly supportive of the wraparound project. The city supervisors have been incredibly supportive. But we also really owe a lot to the San Francisco General Hospital Foundation and Matt Ingram here from the Meta Fund. These are absolutely essential parts of our program, and we wouldn't be here without it. The National Network of Hospital-Based Violence Intervention Programs started as a group of 8 of us who found each other, mostly ER docs, but a couple of lowly trauma surgeons. And we meet on a regular basis. We talk monthly. And we're now a group of about 35. We provide technical assistance through the country. I wasn't even involved in the last group that came through, and the guys just took care of it and provided a lot of insight so that people can avoid some of the pitfalls we went through when we were starting up. But I look forward to opportunities to work with all of you because we're all doing the same sort of thing. But with that, I want to leave it open. So Mike and Javier are 2 of our great case managers, and I just do the PowerPoints.
So modest.
Thank you very much. So, questions, comments?
Hi, Rochelle. She operated on my patient's gallbladder, so she does more than just this.
Awesome.
That was hideous.
That was unbelievable, I know. Total wraparound on that one. Other public hospitals in California that are doing this, Highland Hospital, or I was thinking both in terms of evaluation, because there are probably public hospital systems that aren't doing it. That could serve as a comparison group, and then wondering about spread to other public hospital systems.
So Highland does do it. It's not hospital based, it's hospital linked, and those links I just learned a couple weeks ago are are falling apart a little bit. So I actually need to grab one of the trauma surgeons there and see what's happening so that we can try to help them. But through Youth Alive, caught in the crossfire, and they helped tremendously putting some of the ideas in our head about wraparound. So to see that kind of, okay, what's going on there. So they have a program, but I have to sort of see how healthy it is right now. There is a fledgling program in LA right now, but County USC doesn't really have, it's not up and going, and I think they struggle with funding. They've been trying to put it together. UCSD just asked us about a program, but they don't have one right now, and UC Davis does. They have a program there. They have a couple of different level 1 trauma centers, but they have.
Yeah.
Fresno is actually starting. But that's the way we're developing a registry, a database right now, to look at just the outcomes. It's retrospective, and then it will be fed in as more of an observational. There are the 8 initial programs, the pilot prevention programs in the country are going to contribute to this database. We're hoping this helps in moving policy forward to say, if you have a particular level of burden of injury, violent injury in your public hospital, you need to have this as part of your level 1 trauma center staff package. We'll see how that goes.
Yes.
Feel free to ask.
Yeah, I have a question for you all about the gender balance of the group. And obviously, probably is more common among males, but I was wondering if you could speak to females in the program.
Yeah, we've been pretty successful at establishing relationships with some of the young women that are coming by. To this day, fortunately enough, there hasn't been a real situation where I felt I had to bring some feminine energy in, or just actually refer this case out to maybe a woman that could probably, that I know is out there doing the same type of work in the community. Because you gotta really look out for that. You know, they don't necessarily want your help, and there could be, you know, this barrier that they're creating that, you know, you really have to look out for those triggers, and we're pretty good at that. We're pretty good at really understanding like this relationship could be something great, but it's probably I'm not the one. You know, maybe I need to bring in somebody else. So with that being said, as of right now, I've had a good amount of girls in my caseload, and it's been a pretty healthy relationship. I do bring in, you know, when I think about, you know, mental health service providers and other type of you know, partners that I'm gonna bring into this case, you know, definitely try to link them up with a girl in case something isn't being said with, you know, me. So yeah, we really look out for that, you know, and then somewhere down the line when funding gets better, when funding comes more to wrap around, it'll be somebody we bring in as well. We definitely need that in our team. Absolutely.
I'm just curious about, so it sounds like you guys, the case managers, are sort of the secret sauce, and no offense, Rochelle.
She'd be the first to tell you.
Chase gallbladders.
So can you just talk, you mentioned that you're hiring someone right now. Can you talk about the extent to which that is sort of the barrier for growth of the program, or like how hard is it to find the right person, and what is the right person? And I'm also curious about burnout with the job. It seems like it must be hard.
Definitely. Well, the first question, yeah, you know, things cosmically just align themselves with the group we were working with. Just like awesome, you know, Mike Quesada and myself. He and I were working at juvenile hall together, so we'd always run into each other at court. And so he told me about the program. I was brought in, and then we were able to hire Ricardo, who is an amazing, you know, individual in violence prevention, doing the work we do. And then now we have Ruben Marquez, who just, you know, wasn't employed at the time, and it's just worked out, you know, perfectly. It's getting a little bit more difficult to try to find that person that can be part of this team. You know, you really have to be ready, you know, deep, you know, because I mean, the burnout is for real. I mean, some of the stuff we've seen at the ER, some of the stuff we witnessed, some of the stuff that really gets under my skin, and it's just like, I could break down right now, you know, and I'm supposed to be here to help, you know, and so I felt that, you know, so it's a little challenging. We're gonna find them, you know, we're gonna go, you know, they definitely have to be part of the community. One of the things that, you know, we were all able to bring to the table was just really a long history of working in San Francisco and working with the nonprofits out there, right? Establishing really good relationships, being able to really get our kids into these programs while making a call to, not the program itself, but to that individual in that program, saying, hey, I got this kid, it's really high risk, can you please, no waiting list, please, I need you. So, you know, we pull some strings every now and then because we have a history of work we've done with these people. So that's kind of one of the things we're really looking forward to having, you know, somebody that's been in the trenches, knows the resources, has a really good community rapport, you know, with the young population. So we're out there getting it.
Yeah.
We're out there working to try to identify that person, right? And then
And really just screaming at them just to know if that person can even name the resources, at least 10, right off on top. Because if you can't name 10 resources and put an individual in the resources, it's a disservice for that individual.
yeah, and burnout, you know, TRC has always offered their support for individual, you know, one-on-one, just sessions with us to kind of debrief. We've always had, you know, because we're a pretty tight circle, we've always helped each other debrief after a certain event, you know. Let's go, you know, take a walk, go to the pub, something like that, happy hour. But, you know, it's just really, they're you know, really grateful for having such a solid, great team, you know. But we've also reached out to other agencies that provide like this healing the healer type of work, you know, and really just being able to say, okay, these are methods of how to, you know, really keep yourself balanced with this stressful work and whatnot. So we reached out to that. Yeah, there was a big session on healing the healer that Ariel Roberto Vargas did, and you know, he noticed the work we were doing and some of the community partners were doing, got some funding to say, hey, let's do this curriculum because you guys are, you know, there all the time. So that was really, that was a pleasure to do. But we keep an eye out for that. You know, we go to conferences in Philly and stay a few extra days. They treat us nice out there.
Other, Sam? Thanks for the presentation, really new area for me to see and really impressive. So I may ask a kind of naive question, but do you guys do any work that connects any of the advocacy work out there in terms of, I actually originally thought this was a talk about the bullets themselves, but doing work around getting rid of, you know, either the issues of availability of, you know, the most deadly weapons or bullets or guns or those kinds of issues?
You know, we're tied in to the public defender's office that is kind of, you know, spearheading some of the team. Let me see, you know, what is that, that group of attorneys that does, that work with, gun violence?
Oh, it's
You know what I'm talking
Yeah.
about. They're always kind of picking our brain to
Yeah.
yeah, no, but you know, we
There's a group. And
what's good about that is that actually we're being called upon to provide statistics, to provide information that these politicians don't have, that the city doesn't have, you know, city supervisors, they know that. I think in San Francisco it's just kind of brushed under the rug when a 16-year-old is shot and no one really hears about it, you know, but we'll hear all day long about the Oakland mess, you know, all day long, but hardly ever comes out into the media out here, you know. And what really got to me was when we were able to skip these statistics, we were, you know, once a year, or 2 days out of the year, 50 to 80 programs go in front of the board of supervisors and they're like, please don't cut us, please, we're doing great work, we're saving lives, don't cut us. And that's always, you know, the same, everyone's voice is pretty much the same. Don't cut us, we're saving lives, we're helping the community. And one thing I said to them when I was there the last time, you know, it's just, we're not just only saving lives, but we're saving you guys X amount of dollars for the work we're doing. And a few of them stopped texting, and they were like, "What did he say?" You know, and now we're being heard. You know,
That's the litmus test.
it's a mess. I don't know if I answered your question, but some of the things that Nancy Pelosi's office has reached out to us to talk to come up with some figures and understand the problem, and so some of that stuff we're gathering is really being helpful for that.
And then to add to just, at bedside, talking to the youth, the city and nobody can really measure by us going to that bedside, getting at a guy that may retaliate. So you saving a life by even just getting at that individual to stop him from retaliating. So.
Yeah, it's hard to calculate
It's
that
hard to
number, how many
calculate that.
guys we've actually stopped. You know.
Yeah, it's interesting, the Congress people in the area are asking us for data and statistics, and then the American Association for the Surgery Trauma and the American College of Surgeons asked us to help write a statement after Newtown about semi-automatics and so forth, so it's good, because, yeah, it gives us enough to tackle that stuff.
Okay, I was just curious if you offer case management services in other languages besides English.
Yeah. No, but if there's those barriers, like our Asian community, we're tied up with the API community out there, so we'll know like, hey, we're not breaking any ground here, especially because there is this language barrier, but sometimes it's just a culture barrier. Sometimes it's just like, we don't deal with anyone outside our culture, especially when it's like this heavy-heated type of situation, So we'll bring in some of the guys that we work with and closely with the API community very well.
Terrific. All right, well, thank you all.